Hi everyone, this is Doc Ina, and the lecture for today is on the polycystic ovary syndrome. To download this lecture deck for free, please go to my WordPress site, Doc Ina Obigaine. Main reference for this lecture is Comprehensive Gynecology 7th edition, Chapter 41, Polycystic Ovary Syndrome. This is the outline of our lecture. First, we discuss the different criteria for the diagnosis of polycystic ovary syndrome. Then we also discuss the pathophysiology, the health consequences, and finally the treatment for polycystic ovary syndrome. Polycystic ovary syndrome, or PCOS, was originally described in 1935 by Stein and Leventhal as a syndrome consisting of amenorrhea, hirsutism, and obesity in association with enlarged polycystic ovaries. This is the most common hormonal disorder among reproductive age women, and its average prevalence worldwide is about 5 to 8%. Here is a list of the different definitions or criteria that we can use to diagnose polycystic ovary syndrome. But the most commonly used definition worldwide is the ROTTERDAM criteria. This criteria emerged following a European Society for Human Reproduction and Embryology and American Society for Reproductive Medicine, or ESHRE-ASRM conference in 2004. Menstrual irregularity, symptoms or findings of hyperandrogenism, and polycystic ovaries on ultrasound are the three criteria used in this definition, but only two of these three criteria are required for the definition. However, before we label a patient as having polycystic ovary syndrome, we must exclude other underlying hormonal disorders or tumors such as non-classic adrenal hyperplasia, Cushing syndrome, androgenic tumors, hyperprolactinemia, and thyroid disease. That's why we sometimes call polycystic ovary syndrome as a diagnosis of exclusion. Here is another closer look at the ROTTERDAM criteria. So as I've mentioned, we need to fulfill 2 out of the 3 criteria in order to diagnose a patient as having polycystic ovary syndrome. And the components of this ROTTERDAM criteria are hyperandrogenism, menstrual irregularity, and polycystic ovaries on ultrasound. Now for hyperandrogenism, this can be manifested as either clinical hyperandrogenism or biochemical hyperandrogenism. Clinical hyperandrogenism is manifested as hirsutism, acne, androgenetic alopecia, and acanthosis nigricans, whereas biochemical hyperandrogenism is manifested as high circulating levels of testosterone or androstenedione. Menstrual irregularity, on the other hand, is manifested by oligomenorrhea or amenorrhea, or when we look at the laboratory values, these patients usually have high levels of luteinizing hormone. Now for polycystic ovaries, this is manifested on ultrasound as having more than 12 follicles in each ovary, with a follicle size between 2 and 9 millimeters, and or an ovarian volume of greater than 10 ml. Now, to diagnose a patient with polycystic ovary syndrome, you need just at least one ovary to be polycystic and not necessarily both ovaries. As discussed previously, ultrasound morphology has become an important parameter in the diagnosis of PCOS. And the picture on the right, as you can see here, this depicts the typical appearance of the polycystic ovary by ultrasound in a sagittal plane. However, this ultrasound picture of a polycystic ovary has become one of the pitfalls in the diagnosis of PCOS. Most obstetrician gynecologists would label a patient as having PCOS just on the basis of a polycystic appearing ovaries or a polycystic ovarian morphology on ultrasound. Now, remember, to be able to diagnose a patient with PCOS, you must fulfill 2 out of the 3 criteria of the ROTTERDAM criteria. A patient who has a polycystic ovarian morphology or a polycystic appearing ovaries on ultrasound does not necessarily mean that the patient has polycystic ovaries. You need to ask yourself, does this patient have hyperandrogenism? Does this patient have menstrual irregularity? Now, if you fulfill at least 2 of the 3 criteria, then that's the time you label a patient as having PCOS. A patient who has a polycystic appearing ovaries or a polycystic ovarian morphology on ultrasound only means that she is anovulatory and not necessarily have PCOS. Remember, 10 to 25% of the normal reproductive age population may have polycystic ovaries found on ultrasound. And PCOM should not be confused with the diagnosis of PCOS. But this may be a risk factor for other features of PCOS such as insulin resistance and cardiovascular risk factors. So based on the Rotterdam criteria, we can identify 4 different phenotypes of PCOS. So there's type A, type B, type C, and type D. So the type A phenotype is a patient with PCOS who have all 3 criteria, meaning she is hyperandrogenic, anovulatory, with polycystic ovaries on ultrasound. The type B phenotype is a patient with hyperandrogenism and chronic anovulation. Both the type A and the type B are what we call the classic PCOS. Type C phenotype is a patient with PCOS who is hyperandrogenic and with polycystic ovaries on ultrasound, and this is what we call the ovulatory PCOS phenotype. Finally, the type D phenotype is a patient with PCOS who is anovulatory and with polycystic ovaries on ultrasound. This is what we call the non-hyperandrogenic phenotype. This is a very nice diagram depicting the pathophysiology of polycystic ovary syndrome. So remember, the central pathophysiology for PCOS is insulin resistance. Obesity and dyslipidemia are not part of the criteria for PCOS, but these are factors that exacerbate insulin resistance. These are factors that contribute to higher levels of insulin resistance in the patient. So with insulin resistance, we expect higher levels of insulin in the bloodstream, or what we call hyperinsulinemia. With hyperinsulinemia or high levels of insulin in the bloodstream, this stimulates the ovaries to produce more androgen, and therefore this leads to hyperandrogenemia or high levels of androgen in the bloodstream. Thereby, this manifests as hyperandrogenism like acne, hirsutism, alopecia, and seborrhea. The increase in androgen also has direct effects on the ovary to increase follicle number and follicle size and possibly enhance granulosa cell responsiveness to FSH. The increase in androgen also inhibits steroid negative feedback effects on hypothalamic gonadotropin releasing hormone pulse generation to account for the rapid LH pulse frequency observed in women with PCOS. So remember, in the two-cell, two-gonadotropin theory, we discussed that LH stimulates the production of androgens in the theca cells, right? So if we have high LH, therefore we expect higher production of androgen in the theca cells of the ovary, and therefore that will also lead to hyperandrogenemia. Now, the excess androgen can also be converted to estrogen in the ovaries, right? As you learned in the two-cell two-gonadotropin theory. Now, the excess estrogen will send a negative feedback to the pituitary, and therefore, what will happen is that the FSH levels will decrease. And you know the objective or the goal of FSH is to stimulate the growth of the follicles, and with a very low FSH, then that will be inadequate to stimulate the growth of the follicles, and therefore what we have is polycystic ovaries because we have follicles that remain in the immature state. Okay, so if we have follicles that did not mature or did not grow, then the patient will not ovulate, leading to what? Anovulation, and therefore menstrual irregularities. More and more newer studies on PCOS have consistently shown that Insulin resistance is not the only factor that contributes to the development of PCOS. Actually, nowadays, PCOS is considered as a complex multigenic disorder with strong epigenetic and environmental influences such as lifestyle and diet. The characteristic endocrinologic features in polycystic ovary syndrome include abnormal gonadotropin secretion caused by increased gonadotropin-releasing hormone pulse amplitude or increased pituitary sensitivity to GnRH. These abnormalities result in tonically elevated levels of luteinizing hormone or LH. The high tonic levels of LH is often referred to as inappropriate gonadotropin secretion, and this is due to elevated androgen and unbound estradiol or hypothalamic pituitary functional abnormalities related to neurotransmitters such as dopamine. Because FSH levels in women with PCOS are normal or low, an elevated LH-FSH ratio has been used in the past to diagnose PCOS. However, an elevated LH level or an elevated LH-FSH ratio is neither specific for nor required for the diagnosis of PCOS. Women with PCOS have increased levels of biologically active non-sex hormone-binding globulin-bound estradiol, although total circulating levels of estradiol are not increased. The increased amount of non-SHBG-bound estradiol is caused by a decrease in SHBG levels, which is brought about by the increased levels of androgen and obesity with high insulin levels present in many of these women, as we have discussed in the pathophysiology. Estrone levels are also increased because of increased peripheral conversion of androgen to estrogen in the adipose tissue. The tonically increased levels of biologically active estradiol may stimulate increased GnRH pulsatility and produce tonically elevated LH levels and anovulation. This relative hyperestrogenism, which is unopposed by progesterone because of anovulation, increases the risk of endometrial hyperplasia in women with PCOS. Androgens from a variety of sources are also elevated in women with PCOS. Serum testosterone levels usually range from 0.7 to 1.2 nanograms per ml, and androstenedione levels are usually from 3 to 5 nanograms per ml. In addition, approximately 50% of women with this syndrome have elevated levels of DHEAS, suggesting adrenal androgen involvement. However, not all patients with PCOS who have high levels of androgen manifest with clinical hyperandrogenism such as hirsutism or acne. The presence or absence of hirsutism will depend on whether those androgens are converted peripherally by 5-alpha reductase to the more potent androgen, dihydrotestosterone or DHT. Here are some of the physical manifestations of hyperandrogenemia in PCOS. Among others, patients may present with acne, hirsutism, or alopecia. The type of acne in hyperandrogenemia in PCOS is usually the inflammatory type and is mainly localized in the chin, the neck, and the thorax. This is the type of acne that is persistent and poorly responsive to topical dermatologic therapy. The acne severity can be graded on the basis of the lesion counts. The presence of moderate or more than 10 facial lesions or severe inflammatory acne through the perimenarcheal years is uncommon. So the presence of moderate to severe inflammatory acne vulgaris that is persistent and poorly responsive to topical treatment should prompt investigation on hyperandrogenemia and PCOS. The next clinical manifestation is hirsutism, which is moderate to severe with a peripubertal onset and with a slow progression, which is consistent with PCOS. Hirsutism should be objectively quantified according to the modified FERRIMAN-GALLWEY score or the MFG score. Due to ethnic or genetic differences, hirsutism may be a less prominent feature among Asian women. This is the modified FERRIMAN-GALLWEY scoring. So as you can see here, the MFG scoring has 9 body parts, mainly the chin, the chest, the upper abdomen, the lower abdomen, the upper arm, the thighs, the upper back, and the lower back. Obtaining a score of less than 6 to 8 is the normal. A score of 8 to 15 denotes mild hirsutism, and a score of more than 15 denotes moderate to severe hirsutism. Isolated mild hirsutism should not be considered clinical evidence of hyperandrogenism in the early postmenarcheal years. Moderate to severe hirsutism constitutes clinical evidence of hyperandrogenism. Another clinical manifestation of hyperandrogenism is alopecia, especially when it affects the vertex or the crown area. Also, with PCOS and hyperandrogenism, we inspect for the presence of acanthosis nigricans, which is a velvety, dark discoloration of the creases in the body. And this is usually indicative of insulin resistance. Cushingoid features, blunting of facial features suggestive of acromegaly and signs of systemic illnesses. Also, we measure the body mass index of the patient. So if the BMI is more than 25 kilograms per meter squared, that suggests obesity. And also, we measure abdominal adiposity because, as I've said in the pathophysiology, the adiposity or being overweight or obese exacerbate insulin resistance. The importance of diagnosing PCOS is that there are known long-term consequences of the diagnosis warranting lifelong surveillance. These include metabolic and cardiovascular risks as well as the risk of certain cancers with aging. So generally, with PCOS, you expect some health consequences or long-term health risks such as the development of diabetes mellitus, and a patient with PCOS has a 10-fold risk of developing type 2 diabetes mellitus during adulthood. PCOS patients also have a 2-fold increased risk of developing metabolic syndrome, especially those patients who are obese and have very high triglyceride and cholesterol levels. Infertility and endometrial cancer are also long-term health risks for these patients. Early intervention and counseling might be the key for prevention of comorbidities of PCOS. Now, this is a very nice schematic representation of the change in emphasis from early age reproductive disorders to long-term metabolic and cardiovascular health. Whereas before, PCOS was seen to be largely a concern among reproductive age women only, nowadays, there's a bit of a change in the health paradigm with regard to PCOS. Now the emphasis is more of the long-term consequences of PCOS. So this diagram now depicts the shift in the emphasis with aging, which requires a multidisciplinary approach. Now with aging, concerns for cardiovascular disease, including hypertension, metabolic syndrome, diabetes, and cancer become more prominent. Now, this is also a schematic representation of the same long-term health risk. And we see here that one of the long-term consequences or health risks in patients with PCOS are the development of ovarian cancers, endometrial cancers, diabetes mellitus, cardiovascular diseases, and hypertension. Weight gain as women age is a major predictor of abnormal metabolic findings and the emergence of cardiovascular disease risks. Indeed, all the symptoms of PCOS are worse with increasing body weight. There is increased abdominal and visceral fat in women with PCOS, and this has been correlated to insulin resistance and metabolic dysfunction. Therefore, lifestyle management has to be a priority for these women with PCOS and must be maintained lifelong. Metabolic syndrome, which is largely driven by obesity and leads to diabetes and cardiovascular disease, has a prevalence during the reproductive years. The diagnosis of metabolic syndrome is made using the adult treatment panel 3 criteria, and we have to fulfill 3 out of the 5, and the criteria are as follows: a waist circumference of more than 88 centimeters, high density lipoprotein less than 50 milligrams per deciliter, triglycerides more than 150 milligrams per deciliter, blood pressure of more than 130 over 85 millimeter Hg, and a fasting blood sugar of more than 110 milligrams per deciliter. Again, you have to fulfill about 3 of the 5 criteria before you diagnose metabolic syndrome. The constellation of risk factors that make up metabolic syndrome will place women with PCOS at increased risk for cardiovascular disease and diabetes, but there is nothing specific of more significance regarding metabolic syndrome in PCOS. Type 2 diabetes mellitus is more prevalent, about 2 to 3 times higher, among women with PCOS of reproductive age. This is driven by insulin resistance, which in turn is worsened by overweight status and menstrual irregularity. Thus, it is extremely important to screen for diabetes in the overweight population with PCOS. It has been suggested that this is best done with an oral glucose tolerance test, and not just a fasting blood glucose level. HbA1c is really not a good screening method, but it is useful in the follow-up of women as they are being treated. Diet and exercise are the mainstays of treatment for patients who have diabetes and are obese. Metformin at a dose of 1,500 milligrams per day may be given for at-risk women and those with glucose intolerance and pre-diabetes. Women with PCOS have characteristic lipid and lipoprotein abnormalities, including the presence of abnormal lipoprotein particles, which adds to a long list of abnormalities that tend to increase cardiovascular risk. Women with PCOS should be counseled regarding cardiovascular risk factors and preventing hypertension, dyslipidemia, diabetes by lifestyle modification and other means. Now, this table shows us a very long list of risk factors noted among PCOS patients that make them susceptible to cardiovascular diseases. Now, the traditional risk factors include being obese, having insulin resistance, dyslipidemia, abnormal homocysteine, C-reactive protein, plasminogen activator inhibitor 1, increase in inflammatory adipocytokines such as TNF-alpha, a decrease in adiponectin, and a higher prevalence of diabetes and hypertension. For atherosclerosis, coronary catheterization studies increase in carotid intima media thickness and coronary calcium. And for the endothelial dysfunction by blood flow studies, all increased in classic PCOS and less of a concern with milder phenotypes using the ROTTERDAM criteria. Endometrial cancer is increased by about 2 to 3-fold among patients with PCOS, especially those patients who are obese. Endometrial cancer can begin at a younger age among PCOS patients, and this is because of the long-term anovulation condition in these patients and unopposed estrogen stimulation of the endometrium. There is also note of a defect in progesterone signaling in the endometrium of PCOS patients who develop cancer. The risk for ovarian cancer is also 2.5 times increased among PCOS patients. However, breast cancer does not seem to be increased among women with PCOS. This level of risk for endometrial and ovarian cancer can be brought down to a normal rate with the use of oral contraceptives. The decreased risk of these cancers with the use of oral contraceptives for about 5 years is very well known in studies, and this translates into a good strategy for normalizing cancer risk in women with PCOS, particularly because many women normally would be treated with oral contraceptives in any event for other symptoms of PCOS. Also of interest is that there is a growing body of evidence that metformin, which may also be used for women with PCOS, has inhibitory effects on various cancers, and the data are strongest for endometrial and breast cancers. Treatment of women with PCOS should be directed at the specific complaint, and these concerns fall into three main categories. Number one is androgen excess and symptoms of hyperandrogenism. Second is irregular bleeding and risk of endometrial disease due to unopposed estrogen stimulation from anovulation. And the third is fertility concerns and subfertility, mostly due to anovulation. In addition, a common complaint is weight gain or the inability to lose weight. This is also related to insulin resistance and metabolic concerns. Accordingly, regardless of the complaint, lifestyle management is an extremely important component of any treatment regimen. Specific treatment for androgen excess symptoms usually involves the use of an oral contraceptive with or without an anti-androgen. Treatment of irregular bleeding should be directed at supplying the missing progesterone in anovulatory women. This potentially can lead to endometrial hyperplasia or cancer if not treated. Women who are overweight and older are a higher risk group, and endometrial biopsy may be indicated, although there are no validated guidelines as to when a biopsy should be carried out. It is also important to remember that it is the women with PCOS along with menstrual irregularity who have insulin resistance and are more likely to have metabolic dysfunction. Oral contraceptives are the most logical and effective treatment, particularly because it is known that they reduce the risk of endometrial cancer. Oral contraceptives may also be indicated for the treatment of symptoms of androgen excess. In other women, progestogen therapy alone may be used at 2 to 3 month intervals to shed the endometrium in chronically anovulatory women. Medroxyprogesterone acetate at 5 to 10 mg or norethindrone acetate at 2.5 to 10 mg may be used in this setting. Treatment of subfertility in PCOS is predominantly due to anovulation. Even women with the ovulatory phenotype C may have subtle ovulatory disturbances, and it is known that some women with or have endometrial defects in progesterone and insulin signaling. Prior to treatment with ovulation induction, it is very important to rule out other fertility factors, specifically male factors, by obtaining a semen analysis. Before ovulation induction, it is necessary to normalize overt abnormalities in glucose tolerance and to encourage weight loss for overweight women. Ovulation induction may be accomplished by a variety of agents such as metformin, clomiphene citrate, letrozole, gonadotropins, and pulsatile GnRH, as well as ovarian diathermy or drilling. Adjunctive measures include the use of dexamethasone, dopamine agonist, thiazolidinedione, and various combinations of these options, although today, these agents are rarely used. IVF stimulated or unstimulated may be indicated in difficult to manage cases or if other infertility factors are present. Clomiphene has been the mainstay for ovulation induction, and most pregnancies occur within the first few cycles. Letrozole at a dose of 2.5 to 5 mg per day for 5 days has proven to be efficacious as an alternative to clomiphene citrate, and it is particularly suited for women who have side effects with clomiphene. Low-dose gonadotropin therapy is also highly effective as a second-line treatment for failure with oral agents and for occasional patients who may have transitory low estrogen status. Ovarian drilling or diathermy is a reasonable second-line therapy also, particularly in clomiphene failures and when gonadotropin therapy has proven difficult. For women who fail to conceive with ovulation induction over 6 cycles and in those with other infertility factors, then IVF is the next best step. The only caveat to IVF treatment in women with PCOS is the higher than normal risk for ovarian hyperstimulation syndrome, or what we call OHSS. The mainstay of treatment for all PCOS patients should be lifestyle modification, and this is the key management strategy that should be directed at altering lifestyle variables, especially weight. Metabolic syndrome is usually treated by a combination of diet and metformin. 6 to 12-month therapy has been shown to reduce weight by as much as 5 to 7%, as well as to reduce insulin resistance and improve metabolic parameters. Positive results have also been reported with the use of bariatric surgery in obese women with PCOS, where most of the symptoms of PCOS were found to disappear after surgery. Now, these are the proposed treatment for women with polycystic ovary syndrome according to the complaints. So, if the chief complaint is infertility, then the treatment options will include letrozole, clomiphene citrate, with or without metformin, gonadotropins, or diathermy or ovarian drilling or cautery. For skin manifestations, we can give oral contraceptives with or without actually an anti-androgen, or we can also give GnRH agonist. For abnormal uterine bleeding, we can give cyclic progestogens or oral contraceptives. For weight and metabolic concerns, of course, the first line would be diet and lifestyle management with or without metformin. Thank you for listening and watching my lecture, and please don't forget to subscribe to my YouTube channel and my WordPress site.